started your timer and here is your question. Right, so if you have read and understood, considering a critical care scenario, kindly tell me, how would you manage this patient now?
First, I will wash my hands and introduce. Hi, I'm Dr. Mo, one of the surgical candidates here. I will start by care of the critically ill surgical patients by going off A, B, C, D, E approach. So first start with airway. If the patient is breathing really well, or if there is any obstruction, check also for breathing, check the SpO2 level, and then check the chest expansion. Also listening to auscultate the chest if there are any sign of pneumohemothorax. For C, the blood pressure, heart rate, assess the blood pressure, heart rate, and capillary flow time. And then for and then stabilize the patient and check any injuries or other places.
Yes, what measures would you take to stabilize the patient?
Heart collar, neck, and sandbags.
Okay, with tracheal dates. Okay, and
and then intubate the patient because this patient has his GCR has dropped to 8, and also he had amnesia evidence, and he has vomited twice, which are the indications. Which are the severe indications, high risk criteria. Retrograde amnesia is median risk criteria.
All right. Okay. Can you please tell me how would you take care of the fluid requirement of this patient now?
Start with increasing the venous return. So for the patient's position, lift the head to 30 degrees. And then make sure that anything, including neck collars, are not obstructing the neck veins. For the position,
these answers are not answering fluid requirement. Jump straight to the answer. How much you would give instantly, and then what would be the maintenance amount you'll give afterwards? Over how long?
Yeah. Also, the good neck alignment is required. To reduce cerebral edema, I will use mannitol, 20% mannitol at 0.5 to 1 gram per kilogram. I can also use furosemide, 0.5 to 1 milligram per kg, and that is also I will maintain the sodium level at 140 and 145 millimole per liter.
Right. Thank you. Can you please tell me, considering that patient has had 15 Glasgow scale, and now after a while it has dropped down to 8. What does this condition called? And patient is having amniotic events as well.
I think it means the patient has a lucid interval.
Yes. Okay. What is lucid interval?
Lucid interval is temporary improvement in the patient's condition, followed by a sudden deterioration in clinical condition, loss of consciousness.
All right. Can you please tell me what are the normal intracranial pressure first?
It's 7 to 15 millimeter mercury.
How can you measure, or what are the ways of measuring intracranial pressure?
By inserting the intravascular catheter, intraparenchymal probe, subarachnoid probe, epidural probe, also MRCS pressure.
Yeah, but you can answer the question nicely, that it can be measured invasively and non-invasively, and then give
Yeah.
examples of each
Okay.
in a better way. Okay, can you please tell me what do you understand by the term Cushing triad?
The Cushing's triad, it consists of the signs, hypertension, reflex bradycardia, and irregular respiration because of
Okay,
monocardiac doctrines.
All right, how is it different from Cushing reflex?
Cushing's reflex is a body's physiologic response, a combination of sympathetic and vagus response system due to increased ICP.
All right, good. Can you please tell me the pathophysiology behind the increased intracranial pressure?
It is due to monocardiac doctrine hypothesis because the skull acts as a bulb which contains the brain 80%, blood 10%, and CSF 10%. When one of the components rises in volume, the other two components have to compensate. If fails, it can lead to irretrievable rising ICP and leading to cerebral brain herniation.
According to the NICE guidelines, when should you ask for CT scan in a patient with head injury?
For CT scan,
yes. What is the criteria according to the NICE guidelines?
Yes, high risk criteria and medium risk criteria. For high risk criteria, the GCS less than 50 2 hours post injury. If the patient is more than 65 or more, the patient has two or more times of vomiting, any head injury patient using anticoagulant, suspected open or depressed scar fracture, and any sign of basic scar fracture, such as
you're telling me why, or I asked you when, how long after surgery?
How long after surgery?
After head injury, I'm sorry, myself getting mixed up. After head injury, when should you go ahead? What is the criteria? When should you do CT scan?
I think okay. Initially.
Yeah. If you know, tell me quickly, otherwise I'll ask the next question and then you can tell me later on. Right.
We can do it initially. Yeah.
Initially, right away?
Right away.
There is a criteria.
Oh, sorry.
Okay,
I think I don't
you
know
have
that.
to tell me. All right. Okay.
Yeah.
Since this patient has increased intracranial pressure, would you or would you not do the lumbar puncture on this patient?
No, this is not okay for a patient to get lumbar puncture.
What are the risks? What are the complications that you should?
It can lead to brain herniation.
Okay. Right. Can you tell me what are the causes of dilated pupils when a patient presents with raised intracranial pressure?
Because the raised ICP, it compresses the oculomotor nerve.
Yes. And then?
Yeah.
These nerves, they carry parasympathetic fibers, and then what?
The parasympathetic nerves. And they are oculomotor nerve is responsible for pupil constriction. Yeah.
There is unopposed sympathetic.
Yeah, unopposed sympathetic
this you have
system.
to tell. All right. Okay. Can you please tell me? You said you will intubate the patient. What readings or how would you place the patient on intubation? So what would you keep in your mind? How would be the setting of the ventilator?
Pardon me?
What would be the settings of the ventilator? How would you do it? What is your aim? What are you trying to achieve out of it?
To optimize ventilation.
Okay, can you please quickly help me read the image?
Yep. There's a biconvex hyperdense area at the right parietal area. And there's also midline shift and compression of ventricles.
And there is midline shift?
Yes.
And
compression of ventricles.
Yes, what are these?
Those are ventricles, lateral ventricles.
Okay, good, thank you. Question. Right. So if you have read and understood considering surgical anatomy patient, kindly tell me what is the dermatome of the brachial plexus?
Okay, it's an anterorami of cervical 5, cervical 6, cervical 7, cervical 8, and thoracic 1.
Okay. How would you mark it on a living human being? Would you be able to,
Sorry, ma'am.
if a pen is given to you, would you be able to mark it on a living human being? Can you tell me the surface anatomy of brachial plexus?
Surface anatomy of ma'am, it's their roots, trunks, and divisions and chords. So
Yes,
roots
but
located
then,
in the posterior triangle between the, yes, ma'am.
yes, but then you have to tell me, like on a human being, how would you mark roots and trunks and chords? Where would you mark them? Which area? Okay, you'll tell me later. Okay, what image are you looking at? Can you identify the structures from A to F, please? A is a
Yes, ma'am.
muscle.
A is a muscles, biceps,
Okay,
and B is a median nerve itself, and C is medial cord. C is ulnar nerve, and D is uh, D is musculocutaneous nerve, and E become the axillary nerve, and F is radial nerve.
can you please tell me from which side this image has been taken?
From which side?
Side,
It's
yes, right side. Okay, can you please tell me
yes, it's the right
how,
side.
yes, how brachial plexus are formed?
Brachial plexus formed by roots, trunks, and divisions
Yes,
and cords,
okay,
and it's originated from the anterorami of cervical 5 to thoracic 1.
thoracic one normally, yes, and then roots are formed. They exit from where? Can you tell me the whole pathway, please?
Roots are located in the posterior. Yes, ma'am. Roots are located in the posterior triangle between the scalenus anterior and medius.
Yes, from there they exit from foramina. Which foramina? Okay, then
Um,
these roots,
ma'am, in intervertebral foramina.
yes, then
It exists from intervertebral foramina.
then trunks,
Between the scalenus anterior and medius.
okay, posterior triangle of the neck, okay,
And
third part of the, yes, then please, I have to ask you to tell
yes,
me. You tell me
ma'am, it's a
fluently, quickly. Yes,
okay, ma'am. Trunks at the base of the posterior triangle of the neck, just behind the third part of the subclavian artery,
yes,
and division just behind the middle 1/3 of the clavicle,
good,
and cords is related to the second part of the axillary artery.
okay, right. And then these cords, they give out branches. Can you tell me how?
Yes, ma'am. Cords are there are three cords: lateral, medial, and posterior cord.
Yes,
Lateral cords, there are lateral pectoral nerve and musculocutaneous nerve, and lateral part of medial nerve.
yes,
And medial cord, there is medial pectoral nerve, medial cutaneous nerve of
good,
arm, medial
good,
cutaneous nerve of forearm, and ulnar nerve, and medial part of median nerve. And in posterior cord, there is axillary nerve, radial nerve, and superior and inferior subscapular nerve, and thoracodorsal nerve.
Okay. Can you please tell me from where these cords have taken their names? Medial, lateral, and posterior. Why are they called so?
Cords are comes from lateral cords are from anterior division of medial and upper trunk,
Yes.
and a medial cord from the inferior division of the lower
Yes. But
lower
why are
trunk,
they
and
called medial, lateral, and posterior? Because of relation to which vessel?
sorry, ma'am.
Okay. You know this actually, you told me. Cords are related to second part of the axillary artery. So because
Cord
of
second
that,
part of
yes,
axillary artery.
yes, because of that relation. All right. Can you please tell me what do you understand by the term Erb's paralysis?
And then Erb's palsy.
Yes, please.
Erb's palsy is a damage of the upper nerve roots, that is C5 and 6.
Yes. Can you please tell me what would be the motor and the sensory? How would the patient present?
Yes, ma'am. Yes, ma'am. In case of a motor affection, there is arm become adducted and internally rotated,
Yes.
and forearm extended and pronated.
Good.
And in case of sensory affection, there is loss of sensation in the radial side of the arm and forearm.
Very good. Okay. How is it different? I'm talking about Erb's paralysis. How is it different from Klumpig's paralysis?
Arms palsy is damage to the upper nerve roots, and Klumpig's paralysis in the lower trunk, that is C8 and C8 and T1. And in case of motor affections, in case of Klumpig's paralysis, there is claw hand deformity.
Yeah.
That means there is paralysis of all the intrinsic muscles of the hand, and paralysis of the wrist flexors except flexor, except paralysis of the wrist flexors and hyperextension of the metacarpophalangeal joint.
Okay, in certain conditions, the brachial fractures are not formed according to the normal C5 to T1. They are called prefixed or postfixed. So when or from where do they arise in that condition?
In case of prefix, there is brachial flexors formed from the C cervical 4, and
Yes.
in case of postfix cervical, there is T thoracic 2,
Yeah.
T2.
Good. Right. Okay. Just few seconds are left. Right. Okay. Time. Good. Thank you.
Thank you, ma'am.
And here is your question. Right. So if you have read and understood, considering its surgical pathology station, kindly tell me, after reading the stem, what are the differential diagnosis that you'll consider for this patient?
Ma'am, most differential diagnosis for this is pathology related to esophagus and stomach.
Yes.
Most likely is the carcinoma of the esophagus. Probably, probably with the background of GERD, it can be a adenocarcinoma.
Okay. What is GERD? GERD? GERD?
GERD is gastroesophageal reflex disease in which
Yes.
mainly it is due to the lax lower esophageal sphincter, which
Yes.
is responsible for this reflex of contents from the stomach into the esophagus. And
What is the relation of GERD with the carcinoma of esophagus?
Ma'am, stomach is lined by columnar epithelium, whereas esophagus is lined by a non-keratinized stratified squamous epithelium.
Yes.
So this columnar epithelium has an protective globulate cells on the superficial surface, protected to the hydrochloric acid (HCl). Sorry. So when the HCl is getting along with the food content getting reflected into the esophagus, the stratified squamous epithelium will be eventually converted into the columnar epithelium. That is nothing but the metaplasia. This condition will be characterized as a Barrett's esophagus, which will later convert into the adenocarcinoma.
Can you define metaplasia, please?
Metaplasia is a change of one epithelium on the pre-existing epithelium due to local factors or environmental factors.
Can you find this metaplasia at any other place other than esophagus that you're mentioning?
Yes, ma'am. Barrett's esophagus. One is in the lungs, other is in the cervix, carcinoma of the cervix,
Okay.
and from where the vaginal epithelium will be.
Yeah. What are the
converting
risk
the-
factors which might have contributed to this condition of esophageal carcinoma?
Ma'am, mainly one is given patient is chronic smoker.
Smoker,
One thing
yes.
followed by gastroesophageal reflex itself.
Okay. Two, any other condition? Does it have to be with the male gender or any food?
Male
that
gender,
patient
yes,
is-
ma'am. Obesity, male gender.
Obesity. Very good. Okay. Yes. What are the management options that you can offer to this patient?
Ma'am, first I would like to investigate the case after
All right,
discussing
good.
with my
First, you'll take the history, confirm, and then yes.
yes,
What
history and confirm.
investigations would you
I would
carry
like to
out?
discuss with my consultant and proceed further with investigations, and specific investigations would be endoscopy, followed by either endoscopic ultrasonography, and if any lesion is found, I would like to perform a biopsy.
Yes.
Then after attending the biopsy report, we'll stage then grade the disease and discuss in the tumor board meeting and given the best possible treatment. Either it is surgically manageable or it is only palliative.
Okay.
If it is surgically manageable, I can perform a esophagectomy followed by anastomosis. Or if it is non-surgically manageable secondary to metastasis, it can be a palliative chemo or radiotherapy.
Okay. What are other conditions which can be seen in case of esophagus?
Yeah, esophagus can be having one is it can be having motility disorders, or it can
Okay.
be precancerous condition, or it can be a malignant condition. Motility disorders are it can be eclasia cardia, or it can be stricture esophagus, or it can be esophageal spasm, or nutcracker esophagus. These are the
Okay.
motility disorders.
What is
Pre-malignant-
eclasia?
Eclasia cardia is a failure of relaxation of the lower esophageal sphincter due to abruption of the ganglions in the
Yes.
esophageal wall.
This condition can also lead to carcinogenous situation. Of the
Yes, ma'am.
patient.
Yeah,
How
it
is
can
it
lead to
different?
squamous cell
Yes.
carcinoma of the esophagus. Eclasia
Yes.
cardia leads to squamous cell carcinoma of the esophagus.
All right. So which one is the most common carcinoma of the esophagus? No,
Adeno
you
is
have told me
commonest.
adenocarcinoma is the commonest. Okay. How would you confirm your diagnosis of carcinoma? of
Ma'am, I would
the-
like to confirm the diagnosis based upon endoscopy and biopsy, and staining the biopsy with immunohistochemistry.
Okay. Right. Once you have confirmed your diagnosis, now you have to plan your management. And in order to know that, you have to know what grade of carcinoma that is. So what are the grading systems that we use to grade the carcinoma of the esophagus?
Ma'am, mainly AJCC of TNM grading, in
TNM,
which
yes.
along with
Okay.
TNM in T1A is high grade dysplasia. First TIS is carcinoma in situ with high grade dysplasia. T1 is involving the mucosa lamina propria or submucosa. T2 is muscularis propria. T3 is adventitia. T4A and T4B. T4A would be of resectable resectable structures involvement, pleura, pericardium, or diaphragm, whereas T3 non-resectable like aorta or trachea or vertebra. And then N1, N2, N3 will be 1 to 2, 3 to 6, more than or equal to 7 group of lymph nodes, N3.
Yes.
M0 no metastasis, M1 being metastasis. G1 will be well differentiated, moderately differentiated, poorly differentiated, and undifferentiated.
Okay. Right. All right. If you come to know that it is grade 2 oesophageal carcinoma, what are the management options that you can offer to the patient?
Ma'am, grade 2, it is a moderately differentiated type of carcinoma.
Yes.
And depending upon the metastasis is present or not for the patient, if it is a systemic
There
metastasis,
is
even
no
if
metastasis. Okay. Yes. Now
Okay.
tell me, please.
If it's
Grade
systematically
2?
metastasis,
Yes.
then we'll go for a palliation. If it is not systematically metastasis, only involving the local esophagus,
Local
depending upon the
involvement, yes.
site of involvement, upper 1/3, middle 1/3, or lower 1/3.
Very
Most
good.
likely in this case, lower 1/3. So I would like to perform a lower esophageal transection with gastric pull-up surgery.
Okay, good. And if a patient presents with a carcinoma in the upper 1/3 of the esophagus, how the treatment option will differ?
If it is the upper one carcinoma,
Yes.
involving the cervical abdominal approach, in this entire total esophagectomy will be planned.
Yes, there's a name of the procedure. I want to hear that.
Yes, and I am able to recall the name of the surgery.
Ivor. Okay. Right. If a patient this patient is young, last question, please. If a patient is elderly and presents with the carcinoma of esophagus in the middle third of the esophagus, what management options or alternatives are available for you then to offer to the patient? The middle third of the
Ma'am, one
It will
either
be
we can
palliative,
do
yes.
sorry, ma'am, it's a young patient with the high grade.
No, I said elderly patient. This is young patient, but if an elderly patient,
if it is
70 plus,
elderly patient,
with the
mainly would
carcinoma
go
in the
for
middle
palliative
third,
treatment.
yes.
Yeah, I would like to go for a self-expanding metallic stent if it is
Okay.
occluding the lumen, or I can go for an feeding jejunostomy
Yes.
for feeding purpose, or I perform a bypass surgery, or using a peg placement, PEG,
Yes. Okay.
for
Good.
gastric feeding.
All right. Okay. Why would you go for self-expanding metallic ring, not for any plastic ring, plastic replaceable or
Self-expanding metallic stent, it has the key to expand the lumen if it is lumen is occluded by the malignancy. When compared to plastic stent, it doesn't have this property, and also metallic stent, the durability and the patency of that metallic stent will be much longer when compared to plastic stent.
Okay, good. Thank you. What is your question? Right. So if you have read and understood, considering it's surgical anesthesia, kindly tell me which bones are you looking at? Can you identify the bone, please?
This is the scapula.
Yes.
Left
What is-
scapula.
Okay, good. What is 2, please?
It is acromion.
All right. Can you identify 14 in picture A, please? Yes. 14, please.
14 suprascapular notch.
What is 10, please?
Spine. The spine of
Spine of the
scapula.
scapula, okay. Can you please tell me what is 5 over here, please?
This infraspinous fossa.
Right. If you can identify 8, please.
8, ma'am. It's the medial border of the scapula.
Okay. Can you please identify 11 in picture B?
This subscapular fossa.
Okay. What is attached over here? If you can tell me.
Subscapularis muscle.
Yes. Can you tell me the origin and insertion of subscapularis muscle, please?
Subscapularis muscle origin in the subscapularis fossa and insertion in the lesser tubercle.
What is the nerve supply of this muscle, please?
And upper and lower subscapular nerve.
Okay, good. Can you please tell me how the shoulder girdle is formed?
It is formed by the glenoid cavity of the scapula and with the head of the humerus.
Okay. Can you please tell me what are the structures which stabilizes the shoulder joint?
Shoulder joint is stabilized by the rotator cuff muscle, which are consist of supraspinatus, infraspinatus, teres minor, and subscapularis.
Okay. In case, what are the common injuries which takes place at shoulder joint? What type of joint is shoulder joint?
Ball and socket type of synovial joint.
Okay.
There may be rotator cuff tear occurs, and shoulder dislocation
Yes.
may happen, anterior or posterior shoulder dislocation.
Can you identify the coracoid process? Which number is
Number 3, madam.
3? Okay. Can you please tell me what are the structures which attach to the coracoid process?
There are 3 structures: coracobrachialis and short head of biceps originate, and pectoralis minor got insertion in the coracoid process.
Yes. So there are 2 ligaments and how many muscles?
3 muscles
And two
and ligament
ligaments.
are coracoacromial, coracohumeral.
And crococlavicular as well.
Coracoacromial.
All right. Okay. You told me about the muscles which stabilize the shoulder joint. These muscles are also called rotator cuff muscles. When there is a tear of the rotator cuff, so which muscle is the most likely one or the most commonly injured?
Supraspinatus muscle tear is the common.
Okay. With the injury of the supraspinatus muscle, patient is unable to do what?
Abduction above 15 degree, 15 to 90 degree.
15 to 90. Yes,
Restricted.
good. All right. Can you please tell me, you told me that the shoulder joint is ball and socket type of synovial joint. What is the role of glenoidal labrum in the stability of the shoulder joint? Here in the image you're looking at.
Glenoidal labrum is deficient in the inferior side, so shoulder joint is most unstable in the inferior portion. So dislocation occur commonly in this side.
Okay. There is another thing as well, which you maybe laxity of the capsule. Capsule is also lax. Yeah, lax. Okay, there are certain triangles over here near the shoulder joint. If you can tell me, what are the boundaries of the quadrangular triangle, quadrangular space and the triangular space, please?
Quadrangular space, superiorly there is teres minor, inferiorly teres major, medially long head of triceps, and laterally shaft of the humerus.
Okay, and what are the contents of the quadrangular space?
Axillary nerve and posterior circumflex humeral vessel.
Very good. Okay, and the triangular space?
In the
What is the, yes, location of the triangular space, please?
triangular space is the boundary of triangular space is superiorly teres minor, inferiorly teres major, and laterally long head of triceps.
Can you please tell me what kind of image are you looking at?
It is a MR arthrogram of shoulder joint,
Yes, which side, please?
right side.
All right, can you please help me and identify the structure, label, and circled blue and one arrow? What is one, please?
Number one is acromion process.
Very good. Can you please identify 4, please?
4 clavicle, right clavicle.
Yes. 5, please.
5, madam, deltoid muscle.
Very good. 7 is a black arrow. Can you please tell me what is 7?
Ma'am, diurnal labrum.
Yes, very good. 6 is a blue arrow pointing at.
6, glenoidal cavity.
Yes, and the last one, 10, please.
10, madam, supraspinatus muscle with tendon. I think tendon.
Okay. Can you please tell me what are the muscles which insert in the bicipital groove?
Madam, bicipital groove, lateral edge, there is pectoralis major, medial edge, teres major, and in between.
Yes. Your voice disappeared. Okay. Can you please tell me, right, posteriorly, which muscles would you be able to see on the posterior of the shoulder? What are the muscles which can be pointed out? Which form the bulk of the posterior of the shoulder?
Madam, trapezius and
trapezius, not exactly. Not forming the shoulder. So there's supraspinatus, infraspinatus, and teres minor. They form the posterior shoulder musculature. The bulk in the back. Okay. And lower. Yeah. Okay, bell bend. Yes, before we leave, can you please tell me the course of the axillary nerve?
axillary, after emerging from the lateral cord, and it passes posteriorly shoulder and emerges through the quadrangular space and
all right. When there is injury to
deltoid
this, yes,
and teres minor muscle.
All right, good. When there is injury
and
to
it surrounds the
this,
surgical neck of humerus.
yes. So injury to the axillary nerve, how would patient present?
There is limitation of abduction movement.
Yes. Inability to
difficulty in
abduct.
initiating the abduction.
Yes, and then there'll be sensory loss of
sensory
badge
loss
area.
over the badge
area.
area.
Very good. Thank you.
Thank you.
Did you, Jen? Right. So if you have read and understood, considering this communication skills statement, can we begin?
Good morning. I'm Dr. Kuldeep. I'm one of the surgical candidate. I'm an orthopedic trainee working under my consultant, Dr. Man. How can I help you?
So, well, it's my turn now for operation because I've been waiting for so long. I've been fasting since yesterday, and I'm really hungry and also angry.
Sorry, sir. Actually, I'm very sorry to say that. Unfortunately, my consultant has been called for one emergency case, emergency road traffic accident, and he was not available to carry out the surgery
Oh.
2 days. I'm extremely sorry.
What do you mean by that? Do you mean that my operation is not an emergency?
Sir, as you are able to walk with difficulty, I can understand that, but the emergency cases has to be given a priority. That's why my consultant is away due to this emergency case. I'm extremely sorry. I know you are frustrated, but the emergency cases need to be given a priority.
Well, so where's the doctor? Will you call him now?
Sorry, sir. As I told you, he is busy with the emergency case and he is not able to pick up your call, sir. But I will inform my consultant about the case as soon as he got free, sir, from the emergency case.
Well, that doesn't make sense anymore because my operation got cancer twice. And if we count this time, it's already the third time. So can I get another consultant?
Sir, I again apologize for the same, sir. But it's your right to get another consultant. But I will afraid that the another consultant take your case from the starting, and then you again have to wait a lot to get a surgery done.
Oh, that's crazy. So what about you, doctor? Could you do this for me? Could you do this operation?
Sir, as I told you, I am a surgical trainee under Dr. Man. I am not authorized to do the surgery without the supervision of my consultant. I'm very sorry for that.
It's been so long.
Can I get you something to break your fast?
Sir, I can offer you something to break your fast. Can I offer you a water or something?
No. I just
got the water and the bread.
Yeah, I just want to know when my next appointment will be because I've been waiting for so long, so many months for my knee. I've been suffering a lot of pain at the moment.
Sir, I am sorry, sir. I know your knee is troubling you a lot. I will provide you some good painkillers, which will help you to reduce your pain and which will not cause you some tummy ulcer or and any stomach ulcers. And I will advise you to do some good physiotherapy as well as non-weight bearing exercises, which will help you to strengthen your knee. As well as I'm not authorized to give you an appointment. I can't promise you to give an appointment, but I will discuss with my consultant as soon as he arrives, sir.
So promise me that my next operation will not be postponed again.
Sir, I am extremely sorry, but I can't promise you because we have to prioritize the emergency cases. But I will keep this in mind that you're before. I will provide you the date as soon as it possible, sir.
Okay, so can I walk now because I have a big family behind to support in terms of financially? Yeah.
Yes, sir. So you can walk, sir. You can walk. There will be some wearing and tearing of the meniscus, but you can remain active on non-weight bearing exercises. Like you can do exercises in swimming pool, and you can do some good physiotherapy to strengthen the muscles around your knee, so that it will help you to strengthen your knee.
So will you write any letter that I can do weight bearing work?
Yes, sir. So I will write to your employer regarding the condition of your knee and the requirement of a leave, if possible, sir. I will write that. And if you want, I can call him for you also.
All right. So I also need another medication because I feel heartburn every single day.
Yes, sir. Sir, I will write you the medication which which will not cause you a heartburn that and help you to relieve your pain around your knee, sir.
All right. Okay.
Please accept my sincere apologies. I just need to summarize what we have discussed, sir. As I know you had been your surgery has been postponed twice, and I will discuss with my consultant regarding the date as soon as possible, as well as I will leave my number with you for if you have any queries. Is there any issue with the?
No.
Yes.
You have any
No.
Yes, the patient
Yeah.
would still go ahead and complain. So you tell the patient
Oh.
how pulse. Yes.
I will leave my number with the nurse here, sir, and you can call me at any you can call me regarding any issues and any queries, sir. Please accept my sincere apologies.
Okay.
Patient still wants to complain against you because this has happened third time. So you tell, you'll make sure you'll be given the patient ELS.
Sir,
form.
yes, you can, sir, go to the patient care advisory also regarding the same, sir, in the hospital, and we will help you in any given circumstances.
All right, doctor. So I think it will happen again. So yeah, it's really difficult for me
Sir,
to deal with
we will
this.
try to do it your surgery and give you a date, and we will try to do that, sir.
Okay.
You
I
still
again
have
say
1 minute.
accept
Yes.
my sincerest apologies. Just accept my sincere apologies, sir. And I can offer, if you want, I can offer you any
Light
any
meal
medication. I can offer you light meal and anything to drink, sir.
Yeah.
If you want.
I want a really big meal. I'm so hungry.
I will arrange a lunch or thing for you, sir.
lunch.
Thank you.
35 seconds are left. You people did so quickly, covered it all well. Good. Would you like to give feedback first? Yes.
Yeah, it was pretty smooth, but I
Yes.
had a water in like in terms of language, hearing a water instead of a glass of water. It's like something is wrong. Yeah.
Yeah. Anything
Yeah,
else?
everything was fine. Except that.
Oh, fine.
Yeah.
But then at the end, patient will still complain, and candidates, it's the responsibility of the candidate that say it open-heartedly that yes, you can still go ahead and do complaint for us. We'll make sure you are provided with the form, and then and then you can fill it in and leave it with the nurse, or because patient wants to complain. So good. Timer, and here is your question. Right. So if you have read and understood, considering the communication skills station, kindly begin.
Hello, I'm Dr. Muhammad. I'm working at the Hospital. I'm working with Superman. I'm going to speak to the ITU registrar to inform him about a case where the patient might require a laparotomy and would like to book a post bed in the HDU. Or am I speaking to, please?
Yes, Doctor, I'm Dr. Saif. I'm the duty ITU registered for today.
Can you summarize your
thank you.
case?
Can you summarize, please?
Yes, a patient who is 70 years old female who had been to the ER complaining of sudden abdominal pain, okay. And also she has a known case of COPD and she's taking steroid. And we are suspecting she might have perforated viscous. So now she's a bit in the HDU. Also, I would like to ask you an advice about the perioperative management.
Okay, what made you think that it is a case of perforated viscous?
Okay. Firstly, on examinations, the patient is protetic thin with a sound it shows intra-abdominal collections. And also on the investigation, CBC shows dropped hemoglobin level.
Thank you. Can you please confirm me what are you planning to give him?
Okay, first I will give her 2 liter. I will give her colloid. If there is no, then I will consider blood transfusion.
Preoperative arrangement do you suggest for him?
Okay, because the patient is taking steroid, also I would like to insert insulin catheter and also antibiotic, and also for because the patient has COPD, I will give the low saturation of oxygens to maintain the respiratory drive. Also, I would like to book a bed in HDU post-operatively.
Okay, please confirm that the ITU admission criteria.
Yes, the 2 organ failure with organ coronary and failure with the possibility of second organ may be affected. And also if patients need mechanical ventilation and he has respiratory failure, and also 1-to-1 nurse care.
As presently okay, that if we cannot take him now.
Okay, I will continue monitoring the patient then until bed is available.
Thank you.
Thank you. Can we summarize what we have went through?
Sure.
Yes, you still have 4 minutes, so you have to ask more, discuss more. So what are the complications that you should look out for since patient is COPD and might be taking steroid?
Yes, the steroid most likely she might complain of a dysphonia crisis.
Good. And yes.
And for the CBT, she might complain of respiratory. So,
and
also for the steroids, you most likely have increased opportunity infections like Epstein-Barr virus, cytomegalovirus, and
yes,
increase the risk of osteoporosis and
yes.
pathological fracture.
How would it affect potassium levels? And since patient will be taking, I don't know if it's my network or your network, your voice disappears in the middle as well. Since patient will be taking steroid inhalers, how do you suggest the steroid requirement would be managed during surgery? During and after surgery? You'll give IV
Yes, I will give her.
hydrocortisone? Yes. How frequently? What would be the dose?
Yes, because this is a major surgery.
Yes.
100 milligram
Yes.
pre-operatively and also post-operatively.
Yes. And you'll also ask for
In the next,
yes,
this will be for the next 72 hours. After that,
you'll
I will
switch it
give
back
her.
to
Yes,
oral. Yes. Good.
yes,
Patient, you will also organize with the post-operative chest care like physiotherapy post-operatively in antibiotics.
yes.
Which antibiotic would you suggest, which will help in wound healing as well? The best
I
antibiotic?
will give antibiotic according to the local process. I will give.
According to
Crown-
NHS policy. Yes.
Yes.
How much oxygen would you give and how?
Because patient has COPD, I will give her if I took 240 to 8% through mask.
Yes. Okay. Can you summarize now all the discussion that we've had until now? Please.
Yes, I have 70 years old female who is going to have a laparotomy because of perforated fiscus, and the plan of management will give her IV fluid and antibiotic, and also I'll do some investigation, ECG, chest X-ray, and also I will insert endocrinologic catheter. Then okay, I will give her IV hydrocortisone. If there is no bed available right now, I will continue
Monitoring,
monitoring
yes.
the patients in the recovery until bed is available.
Yes. And what you discussed about the fluid resuscitation and about hypokalemia?
Yes, I will give her potassium chloride according to the potassium level.
Deficit, yes. Good. Right, thank you.
Thank you.